Well, I was invited to be the discussant at ASCO for the first session focusing on early drug development in patients in a newly diagnosed setting. And there were 3 trials. They were all comparing 4 drugs to 3 drugs. So the title that I had been given by ASCO was Quadruplet Therapy in Myeloma, the more the better, ? And when I went through all the data ahead of time, it was very striking to me to see that adding that 4th drug, you do improve the depth of the response. There are more patients reaching a deep response. We're talking MRD negativity. You can see even deeper MRD negativity. You go beyond the threshold of 10 to minus 5 down to 10 to minus 6. You see more of that also with more drugs. You also see longer clinical benefit that was manifested in longer progression-free survival. And there were also early signs of improved overall survival. So it was a very consistent pattern that you improve clinical outcome, better efficacy if you add a 4th drug. Of course, as a treating physician, you always wonder, is that at the expense of safety? So that was also part of my job to review that. And what the data shows is that you can very safely add an antibody on top of the backbones of traditional 3-drug combinations. And what was also striking is that these trials, 2 of them were for older patients, and for 1 of them, it was for the younger patient population. And these are the so-called transplant-ineligible and transplant-eligible patients. So the point I made clear at ASCO was one of my main observations discussing these 3 studies is how the immunotherapies can be added and deliver better outcome for all patients independent of transplant eligibility. And also looking at the trajectories for outcome in these 2 groups of patients, transplant eligible and transplant ineligible, the gap is getting more and more narrow. And having been in the field for many years, this is really a new phenomenon. So I said that, in my opinion, this is probably one of the main deliveries at this entire session, that the gap is getting more and more narrow in favor of better outcome for all the patients. So is it time to think about retiring this old terminology of transplant eligible and transplant ineligibility? This is something that we came up with 41 years ago, before I was even trained as a doctor. They introduced this idea. So maybe it's time to retire this and think about newly diagnosed patients. That's the space where we want to develop the drugs. And then in the clinic, clinicians can decide whether you want to give chemotherapy in a transplant, even CAR T cells or bispecifics. All these new drugs that are coming will probably change the map. So I said the answer to the question, in my opinion, is yes.